This is Stephanie Huff, and this is the last lecture on metabolism. In this lecture, we're going to be talking about thyroid disease. Just an overview, thyroid gland is a small saddle-shaped gland that wraps around the anterior surface of the trachea. Altered production or use of thyroid hormone, which is TH, affects all major organs. Thyroid disorders are among the most common endocrine disorders, and if left untreated can lead to cardiac disease and ultimately death. First, we're going to talk about hyperthyroidism. It is also called thyrotoxicosis. Looking at the pathophysiology and etiology, this is a disorder that caused by excessive delivery of the thyroid hormone to peripheral tissues. Thyroid hormone is the primary effects. It increases the metabolic rate and protein synthesis. So it affects all major organ systems. It also heightens the sympathetic nervous system's response to stimulation. So they will have an increased cardiac rate and stroke volume. So cardiac output and peripheral blood flow will increase. Over time, this hypermetabolic effects of excessive thyroid hormone causes caloric and nutritional deficiencies. Etiology, it is an autoimmune stimulation, as in Graves' disease. There's an excess secretion of the thyroid stimulating hormone, also known as TSH, by the pituitary gland. Thyroiditis, neoplasms. This is usually a toxic multiglandular goiter. Excess thyroid medications can be a cause. Risk factors for developing hyperthyroidism includes being a woman. They are 10 times more likely to have hyperthyroidism than men. Genetics, family history of Graves' disease makes hyperthyroidism more common. Age, between the ages of 20 and 40 years of age, and an increased iodine intake. Clinical manifestations of hyperthyroidism: they have an increased appetite with weight loss, may have hypermodal bowel sounds, so they're very active, and increased peristalsis, which causes diarrhea. They may also complain of bloating and abdominal pain. They have a heat intolerance, insomnia, palpitations. They have increased sweating. The skin is usually smooth and warm with hair changes. Usually they have fine hair, loss of hair in the scalp, eyebrows, axilla, or pubic areas. They also have emotional liability. Treatment focuses on decreasing the production of the thyroid hormone by the thyroid gland to establish a euthyroid, which is a normal thyroid, and preventing and treating complications. Depending on the age and physical status, medications, radioactive iodine therapy, or surgery may be used. All right, Graves' disease is the most common cause of hyperthyroidism. It is an autoimmune disorder. They have antibodies in the serum that causes thyroid cells to hyperfunction. And patients with Graves' disease will have an enlarged thyroid gland, so they have this big goiter. They will have manifestations of hyperthyroidism. Ophthalmology ophthalmopathy is a disease of the eye. This manifests as proptosis, which is a forward displacement of the eye. This occurs in about 1/3 of the cases. They may also have visual disturbances. Exophthalmos is a forward protrusion of the eye, where it looks like their eyes kind of stick out and they're kind of bug-eyed. The lids often are retracted. They have this characteristic unblinking stare. May also have blurred vision, diplopia, eye pain, lacrimation, and photophobia. They also usually have an inability to close the eye, which causes corneal dryness, irritation, infection, and ulcerations. Other manifestations will be fatigue, sleep difficulties, hand tremors, changes in menstruation. They may have a decreased flow, which may progress to amenorrhea. Older adults may have AFib, angina, or congestive heart failure. These are your hallmark signs of Graves' disease. And so this is a picture of a goiter, and then on the bottom is the exophthalmos. And so basically they have this goiter, the exophthalmos, diaphoresis, so excessive sweating, increased appetite, and in spite of the increased appetite, they have this weight loss. They're usually very nervous. They have a heat intolerance, so no matter what the temperature is, that they're always hot, as well as the menstrual changes. All right, and then continuing with hyperthyroidism, a toxic multinodular goiter is a thyroid tumor that is characterized by small, discrete, independently functioning nodules in the thyroid gland tissue that secretes excessive amounts of thyroid hormone. Manifestations of hyperthyroidism develop slowly with ophthalmopathy, which is your disease of the eye, or dermopathy, disease of the skin. Usually women in 60s and 70s who've had a goiter for years usually develop this. Excessive TSH stimulation is overproduction of TSH by the pituitary gland, usually stimulates the thyroid to produce an excessive amount of the thyroid hormone. This form of hyperthyroidism is rare. It usually results from a pituitary adenoma. Thyroiditis is an inflammation of the thyroid gland, and it's usually from a viral infection of the thyroid. It is an acute disorder that may become chronic, resulting in hypothyroid state as these repeated factors destroy the gland. Thyroid storm is also called a thyroid crisis. It is an extreme state of hyperthyroidism. Thyroid storms are rare today because of improved treatment and diagnostic measures. It's usually a form of untreated hyperthyroidism or a stressor. Usually this is from Graves' disease, or it could be from infection or trauma or untreated diabetic ketoacidosis. It is a life-threatening condition. They have a rapid increase in their metabolic rate from the excessive TH production. Rapid treatment is essential. They will cool the patient with aspirin, which increases the free thyroid hormone, or inducing shivering, replacing fluids, glucose electrolytes, relieving respiratory distress, stabilizing cardiovascular function, and decreasing the thyroid synthesis and secretion. Symptoms of a thyroid storm include hyperthermia with body temperatures 39 to 41 degrees Celsius, which is 102 to 106 degrees Fahrenheit. Tachycardia, systolic hypertension, GI symptoms. They will have abdominal pain, vomiting and diarrhea, agitation, restlessness and tremors, which progresses to confusion, delirium, and seizures. Mortality rate is very high with thyroid storms. Collaboration. The treatment of hyperthyroidism causes a hypothyroid state. So patients need to know the signs and symptoms of hyper and hypothyroidism and be able to report these to their healthcare provider. An important thing is to prevent complications until the hormone levels are brought to a normal level. Diagnostic tests that are used: thyroid antibodies test to see if it's an autoimmune disease as being the cause of the hyperthyroidism, which is your Graves' disease. TSH test is compared with the T4 levels. TSH level is decreased in Graves' disease. Your T4 and T3 levels are also taken. T4 measurement is done to determine the thyroid hormone concentration and to test the thyroid gland function. T3 may also be increased in thyroiditis. T3 measurements are bound free forms of this hormone, and this is used for effective diagnosis of hyperthyroidism. There's a T3 uptake test. It is elevated in hyperthyroidism. The RAI, which is radioactive iodine uptake test. This reveals the shape and size of the gland. It is a thyroid scan. Dose is given orally, and will do the scan after 24 hours after they take the oral medication. Thyroid suppression test. This is used, basically they do the RAI uptake and T4 levels measurements first, and then they will take thyroid medications for 7 to 10 days, and then they will repeat the test. Failure of the hormone therapy to suppress the RAI and T4 indicates a hyperthyroidism. Collaboration. Hyperthyroidism is treated with pharmacological therapies by giving anti-thyroid medications that reduce TH production. And because these medications don't take effect, they really don't have an effect on the release of active hormones that have already been formed. So the therapeutic effects may not be seen for several weeks after starting these medications. And too rapid a decrease in these thyroid hormone levels will cause some cardiovascular symptoms associated with hyperthyroidism. And so a lot of times they will use a beta blocker like propranolol, which is also known as Inderal, as part of the initial treatment while they're waiting for these therapeutic effects to occur. And so this beta blocker, this propranolol, will help decrease that heart rate. Radioactive iodine therapy. And because the thyroid gland takes up iodine in any form, a radioactive iodine concentration in the thyroid is given orally to destroy the thyroid cells so that they produce less thyroid hormone. The results occur in over a 6 to 8 week time period. During the RAI therapy, they are generally not hospitalized during treatment and doesn't require radiation precautions. It's contraindicated in pregnancy because the RAI does cross the placenta, and so they can have negative effects on the fetal thyroid gland. The client will become in a hypothyroid state and will need lifelong thyroid hormone replacement. The adverse reactions of RAI therapy are thyroiditis, cardiac instability due to stored thyroid hormone in the thyroid gland. Clients should be taught how to measure their pulse and notify their healthcare provider if the rate exceeds 100 following therapy until the thyroid hormone levels are released, and then those levels start to diminish. Just remember that everything in hyperthyroidism, everything speeds up. They're in a hypermetabolic state, which is why your signs and symptoms are everything is increased. Collaboration. Surgery. Some individuals have such an enlarged thyroid gland that it can cause pressure on the esophagus and trachea, and that can cause problems with breathing and swallowing. So a thyroidectomy, which is removal of all or part of the thyroid gland, may be needed. Most of the time, a subtotal thyroidectomy is usually done, and it leaves enough of the thyroid gland to produce an adequate thyroid hormone level. Before they do surgery, the patient needs to be in as much of a euthyroid state as possible. The client may be given antithyroid drugs to help reduce hormone levels and iodine preparations to decrease the vascularity and size of the gland, and this will help reduce hemorrhage risk during and after surgery. Total thyroidectomies are usually only needed for cancer, and this does require lifelong hormone replacement because they remove the entire thyroid gland. Alright, and so this is pictures of after somebody has had their thyroid taken out. So these are the kind of dressings that you may see. It's always important to assess the dressing behind the neck, because if they're laying posteriorly, a lot of times if you're just looking at the front, you may not see any active bleeding, but if you look behind them, they may have a lot of blood on that dressing on the posterior aspect of their neck, so that's always important. Postoperatively, you need to assess for tetany, which is from, they will have symptoms of tingling in the fingers, toes, around their mouth. They may also have trouble with difficulty speaking or laryngeal stridor. So you always want to ask them to speak after their thyroid has been taken out, because they could have the laryngeal nerve could have been cut, affecting their speech. You want to assess for positive Trousseau's and Cheboks's sign, and that would indicate low calcium levels, and that would be from accidentally removing the parathyroid gland. And so you can see how the parathyroid gland is very close proximity of the thyroid gland, and so it is easily for them to remove that as well. So once you determine that somebody has hypocalcemia, the treatment is calcium gluconate, slow IV piggyback. And so this is looking at your positive Trousseau's and Cheboks's sign. And the Cheboks's is when you tap on their cheek, and then they have sort of that snarl on that side. Trousseau's sign is you put a blood pressure cuff on their arm, and once it remains in place for about 5 to 10 seconds, then they will start to have those carpal spasms that are noted. All right, nursing process for hyperthyroidism. You want to provide the client education regarding the disease process, the treatment options, and post-treatment self-care. In assessment, you want to get a health history of any other diseases they may have, a family history of thyroid disease, looking at their symptoms, when did they begin, how severe are the symptoms, intake of any thyroid medications, their menstrual history, changes in weight, and bowel elimination. Looking at the physical assessment, you want to assess their muscle strength and tremors, the size of the thyroid gland. You want to assess their eyes and vision, assess cardiovascular and peripheral vascular systems, get a good set of vital signs, listen for the presence of the bruit over the thyroid gland, and assess their integumentary system. These are your NANDA diagnoses for hyperthyroidism. Planning goals may include that the client will report improvements related to their manifestations, describe situations requiring contact with their provider, and explain how to take their prescribed medications. Looking at implementation, the hyperthyroidism is often treated on an outpatient basis, so it's important for the client to understand how to provide self-care, what symptoms to monitor for, and when to call their provider. Emphasis on taking their medications daily and not skipping any doses due to absence of symptoms. So you want to monitor cardiac output, monitor their blood pressure, the pulse rate and rhythm, monitor the respiratory rate and breath sounds. You want to assess for peripheral edema, jugular vein distension, increased activity intolerance. Suggest keeping their environment cool and free of distractions as possible. Encourage a balance of activity with rest. Talking about promoting visual health. Visual changes include difficulty in focusing, diplopia, which is blurred vision, vision loss. If they can't close their eyelid due to exophthalmos, then they are at risk for corneal dryness with infections and injuries. So they could have corneal abrasions or ulcerations. You want to monitor their visual acuity, photophobia. You also want to assess the integrity of the cornea and their ability to close the lid. You want to teach measures for protecting their eye. So they'll need to wear tinted glasses because of the photophobia. They're not able to squint and close their eyes like normal. Then they need eye shields. This also will help for protection. Artificial tears will help keep the eyes moist. Cool moist compresses to help relieve irritation of the eyes. They may need to cover and tape their eyelids shut at night if they don't close. And that just protects those corneas from the sheets and pillowcases. Elevating the head of the bed about 45 degrees to help promote periorbital fluid reduction. You want to have the client properly report any pain or vision changes. We're looking at promoting balanced nutrition. The hypermetabolic state that occurs in hyperthyroidism causes GI hypermotility with nausea, vomiting, diarrhea, and abdominal pain. Although the client may have increased appetite and eat more than usual, weight loss still continues. To help the client maintain an adequate nutrition, the nurse should monitor their nutritional status through lab work, have the client weigh daily at the same time, and keep a record of their weights. In collaboration with the dietitian, you want to teach about diet needs. They will need a high carbohydrate, high protein diet that includes between meal snacks. A lot of times 6 small meals may be needed. Physical changes of hyperthyroidism can include exophthalmos, goiter, tremors, hair loss, increased perspiration, loss of strength, fatigue, weight loss. changes changes in sexual function, amenorrhea for females, impotence for men, and increased libido for both. In addition, they may also have mental status changes such as mood changes, insomnia. A lot of times they are constantly nervous and anxious. This can be frightening for the client and the family. So the nurse needs to help improve body image by establishing a trusting relationship, which opens up sharing between the client and the nurse, so that they feel like that they can express their feelings and their perceptions. You want to encourage the client to verbalize feelings about their self and ask questions about the disease and treatment of the disease. When we're talking about their increased dietary needs, with their caloric intake, they may need an increase of up to 4,000 calories per day if weight loss exceeds 10 to 17% for their height and weight. A pound, 1 pound gained requires approximately 3,500 extra kilocalories. Evaluation of hyperthyroidism. Expected outcomes may include client's cardiac status will stabilize, client will regain or maintain their visual acuity, client takes in appropriate amount of calories per day with no further weight loss, client communicates feelings about changes in their body images with verbalized coping mechanisms. The client explains importance of daily medications and proper self-administration. Now on to hypothyroidism. Hypothyroidism is a disorder that results when the thyroid gland produces an insufficient amount of thyroid hormone. Looking at the pathophysiology and etiology, this is when the thyroid production decreases. The thyroid gland enlarges in an attempt to produce more hormone, and they will end up with a goiter that develops. Older clients usually have a decrease in their T4 levels. A hypothyroid state is also called myxedema, and this term reflects accumulation of non-pitting edema in connective tissue throughout the body. This edema is the result of water retention in mucoprotein deposits in the interstitial spaces. So the face will appear puffy, the tongue is enlarged, and the voice is hoarse and husky. Looking at etiology, hypothyroidism can be primary or secondary. Primary is more common and is caused by congenital defects in the gland, loss of thyroid tissue after treatment or surgery. For hyperthyroidism or radiation treatment, antithyroid medications, thyroiditis. It could also be from an endemic iodine deficiency. Secondary hypothyroidism results from pituitary thyroid stimulating hormone deficiency or peripheral resistance to the thyroid hormone. Medications can cause hypothyroidism. Amiodarone contains 75 grams of iodine per 200 milligram tablet, and it is increasingly being implicated in causing thyroid problems. Estrogens, methadone, amiodarone, and birth control pills increase T4 measurements. your anabolic steroids, androgens, lithium, propranolol, interferon alpha, and interleukin-2 decreases T4 measurements. Although hypothyroidism can occur at any age, it is more common in women 30 to 60 years of age. So risk factors, probably the most common is women over 50 years of age. Those with close relatives with autoimmune condition, and those that have had thyroid surgery, radiation to the neck, or treatment with radioactive iodine are going to be at risk. People that have iodine deficiency are at risk. Iodine is necessary for the synthesis and secretion of thyroid hormone. Iodine deficiency may be from goitrogenic drugs, which block thyroid hormone synthesis. Example of these types of drugs would be lithium and antithyroid drugs. Goitrogenic compounds in foods such as turnips, rutabagas, and soybeans may also block thyroid hormone synthesis. In the United States, iodinized salt helps prevent hypothyroidism from iodine deficiency. Hashimoto's thyroiditis is the most common cause of goiter and primary hypothyroidism. It is more common in women than men and usually has a familial link. The Hashimoto's thyroiditis is an autoimmune disorder in which antibodies destroy the thyroid tissue. Functional thyroid tissue is replaced by fibrous tissue, and thyroid hormone levels decrease. The thyroid tries to compensate in the early disease and enlarges, which causes a goiter. As the disease progresses, though, the thyroid gland becomes smaller. Clinical manifestations of hypothyroidism usually has a slow onset, with manifestations occurring over months or even years. Characteristically, they will have a goiter, fluid retention and edema, decreased appetite and weight gain, constipation, dry skin, and dyspnea. They may also have pallor, hoarseness, and muscle stiffness. Many have decreased sense of taste and smell, menstrual disorders, anemias, and cardiac enlargement. Decreased amounts of thyroid hormone causes abnormalities in lipid metabolism with an increase in their serum cholesterol and triglycerides, so that they have an increased risk in atherosclerosis and cardiac disorders. So basically the pulse is typically slow in hypothyroidism, and sleep apnea is more common. They also have a decreased renal flow and glomerular filtration rate. This decreases the kidney's ability to excrete water, which can cause hyponatremia. And this hyponatremia is a dilutional hyponatremia because of the excess of water that is retained by the body. And so you can see how these symptoms are quite opposite of hyperthyroidism. In hypothyroidism, they are in a hypometabolic state, so everything is slowing down. All right, so myxedema coma is rare, but it is a life-threatening complication of untreated hypothyroidism. It's usually triggered by an acute illness or trauma. It could be from a severe metabolic disorder, such as hyponatremia, hypoglycemia, and lactic acidosis. They will also have hypothermia, so they're always cold no matter what the temperature is. They have shallow edema, especially around the eyes, hands, and feet, and so there's a picture of that. They have cardiovascular collapse and impaired mentation and coma. can be precipitated by trauma, use of central nervous system depressants, failure to take their thyroid replacement medications, could be from an infection or exposure to cold. Treatment addresses the precipitating factors, manifestations, and involves maintaining a patent airway, maintaining fluid and electrolyte balances, electrolyte and acid-base balance, maintaining cardiovascular status, increasing their body temperature, and increasing their thyroid hormone levels. If myxedema coma is left untreated, mortality rate is high. Collaboration diagnostic tests that will be done, they will have a decrease in their thyroid hormone, especially T4. The TSH level may be increased. Pharmacologic therapy, they're given medications to replace the thyroid hormone. Levothyroxine, which is T4, is the treatment of choice. A lot of times your older adults may require lower dosages than your younger clients. Surgery is done if somebody has a very large goiter that causes respiratory difficulties or dysphagia. So a subtotal thyroidectomy may be needed. Nursing process, looking at assessment. You want to get a good health history, looking at the onset, severity of their symptoms, the use of iodinized salt, bowel elimination, any respiratory difficulties, any treatment of head and neck cancers with radiation. Ask them about their diet, any pituitary diseases, treatment of hyperthyroidism with medications or radioactive iodine or thyroid surgery. Physical assessment, you want to assess muscle strength, deep tendon reflexes, vital signs, cardiovascular and peripheral vascular systems, integumentary system, assessing the thyroid gland and their weight. These are your NANDA diagnoses for hypothyroidism. Planning goals may include that the client will have pulse and blood pressure that remain within normal limits. They will not exhibit any arrhythmias. They will have skin that will remain dry, warm, and intact. They will remain free of edema, maintain their visual acuity. They will participate in activities with a normal heart rate, and their heart rate will not get too high or get too low. Their elimination pattern will return to normal. Monitoring cardiac output, you want to monitor their blood pressure. Hypotension could indicate decreased peripheral blood flow. Fluid in the pericardial sac can restrict cardiac function. So you want to make sure that you get a good apical rate and rhythm. Assess their peripheral pulses. Monitor respiratory rate and breath sounds. Suggest the client avoid becoming chilled. Chilling increases their metabolic rate and puts increased stress on their heart. So you want to increase the room temperature, add additional bed covers, and avoid drafts. Explain the need to alternate periods of rest and activity to decrease stress on the heart. Preventing constipation, which is common in hypothyroidism. You want to encourage fluid intake of at least 2,000 milliliters per day. Discuss high fiber diet and foods that are high in fiber. Increase activity as tolerated, and that will help increase the motility of the GI tract. Maintaining skin integrity, you want to monitor their skin for redness or lesions, especially if activity is greatly reduced. You want to provide or teach the immobile client measures to promote circulation, such as turning schedule if they're on bed rest, or teaching them to change positions every 2 hours. Limit the time sitting in one position. They need to shift their weight or lift their body using armrest at least every 20 to 30 minutes. Use pillows, pads, or sheepskin or foam cushions for their bed and or chairs. You want to teach and implement schedule of range of motion exercises. Provide or teach client measures to maintain skin integrity, such as taking baths only as necessary. Because remember, their skin's already really dry, and the more you bathe, the drier it gets, which causes a risk for impaired skin integrity. They need to use warm water and not hot water. Hot water tends to dry the skin. They need to use gentle motion when washing and drying the skin. Use alcohol-free skin oils and lotions to keep the skin from drying out further. Evaluation involve determining whether the client has met expected outcomes, and in the event that these outcomes are not met, they need to make changes to the care plan and modify outcomes. You want to repeat diagnostic tests to ensure proper medication level is being given. So this is the end of the thyroid disorders lecture. And again, as always, if you have questions, let me know and I'll see if I can clarify things.